Hello, everyone, and welcome to our webinar, Difficult Conversations at the End of Life. My name is Lauren Blair, and I am the Provider and Community Relations Manager at Coastal Hospice. Welcome to our Caregiver Academy. We're excited that you're joining us today. This webinar is being presented in collaboration with Tidal Health. Among our attendees today, we are happy to see so many familiar organizations with us. We have colleagues joining from Tidal Health. From Atlantic General Hospital, we have several nursing facilities on with us today: Signature Healthcare at Mallard Bay, Genesis, Alice B. Talls, Berlin, Harrison House. We have several physicians' offices, Dr. Gittleman, Dorchester Family Practice, and many, many other attendees. We welcome everyone and we thank you for joining us. Before we begin, allow me to go over a few housekeeping items. My role today is to help facilitate and handle the behind-the-scenes logistics of the webinar. You may see myself or my colleagues Alejandra and Joy pop up in the chat box to address or help with any technical issues. I want to thank you for your patience ahead of time should we have any. I'll also come back in at the end to discuss the program evaluation. Participants must attend the webinar in its entirety and complete the evaluation in order to receive CEU credits. We ask that you set aside other devices or work for the next hour. We are sure that you will enjoy this program today. To make this interactive, we may ask you some questions from time to time. We will be using the chat feature to communicate with you throughout the webinar. You can access it by clicking on the messaging icon in your meeting controls. When you send a message, please be sure to select all panelists and attendees for the to box so that we can all see your comments or questions. Our webinar today will be moderated by Monica Escalante, President of Coastal Hospice, and we have invited two experts on having these difficult end-of-life conversations to join us here today. Monica has more than 20 years of experience in end-of-life. She is a board member of the Hospice Network of Maryland and a diversity advisory board member of the National Hospice and Palliative Care Organization. Monica, I'll hand it off to you.
Thank you, Lauren. Thank you very much, and welcome everybody. We have over 100 people registered for this webinar. We're very pleased with the way this topic has been received by the audience. And I'm going to start by introducing my panel. And Dr. Ghulam Waris is Coastal Hospice's Chief Medical Officer. Dr. Waris is a hospice and palliative care certified specialist with more than 30 years of experience. He graduated with honors and holds certifications in internal medicine, geriatric medicine, and hospice and palliative care medicine. He taught at the University of Maryland Eastern Shore, at the Rochelle College in New York, at the Eastern Shore Education Center, and the Midwestern University and Malcolm X College in Illinois. He was awarded the Elaine Peterson Award by the Hawley Center in 2001 and nominated for the Governor's Excellence Award in the state of Maryland and the Physicians of the Year by the American Association of Physician Specialists in 2007. It's my pleasure to have Dr. Waris with us today. He adheres to a patient-centered philosophy, and he puts always patients at the top, patients first. We hear that all the time here at Coastal Hospice. Second panelist is Dr. Stacy Cottingham. Dr. Cottingham has more than 30 years of experience in nursing. She holds a bachelor's in nursing, a master's of science in nursing with emphasis in healthcare leadership, and a doctorate in organizational leadership from the University of Maryland Eastern Shore. She has collaborated with Atlantic General Hospital, with Peninsula Regional Medical Center, now known as Tidal Health, and the Community Foundation of the Eastern Shore, where she was Director of Partners in Nursing. At Coastal Hospice, she has had a very successful career, holding positions as QAPI, which is Quality Assurance and Performance Improvement, and Education Manager. She was a Senior Director of Strategic Initiatives, and currently she is the Chief Clinical Officer, where she oversees all clinical services at home hospice, as well as Stansel House and Coastal Hospice at the Lake. Dr. Cottingham has been awarded the Outstanding Graduate Award by the Salisbury University and the Outstanding Pathfinder Award by the Maryland Nurses Association. It is my pleasure to have Dr. Cottingham with us today and to work with her and learn from her. And I know we're going to share some really important information today. So without further ado, we're going to dive into our topic. And because we are offering CEUs, I need to remind everybody of the objectives that we have for today. The first one is to understand the importance of having the conversations about hospice and end of life. The second one is to identify when it's appropriate to have these conversations. The third, to choose helpful words and avoid using terms that are harmful. If one thing you take away from this webinar today is we want you to know that sometimes there are things that could be harmful. And the last objective is to utilize strategies to introduce hospice care and approach end-of-life care. So before we go into the actual topic, we want to say the earlier the better, because we see here in hospice that a lot of these conversations don't happen, or they happen way too late. So the message is the earlier the better, and family meetings are absolutely key. So, but when you're trying to have a family meeting, you know, the words you have in front of you describe what the patients and often the family members are going through. So if we want to take a deep breath and look at these words, there's anxiety, there's depression, there's fear, there's frustration, people are afraid, many are in panic. This is not the most unstressful setting to have a conversation. It's quite the contrary. It's when people anxiety are at the highest of all. So we're going to share with you some tools that were developed over the years to have these conversations, even though the situation might not be the easiest. And the contrary, we know it's the hardest. So I'm going to turn to Dr. Waris. You're going to talk about spikes.
Well, thank you and welcome everybody. It's an honor to be here today and talk to you about this important and difficult topic. So one of the imperatives of healthcare reform is that we create a healthcare system that is patient-centered with shared decision making. And the only way to make it patient-centered is by truly understanding the wishes, the hopes, dreams, and desires of our patients, but not only at their best times, but also as they pass through difficult portion of their journey. And the only way truly to capture that is through advanced directives. A little statistics about advanced directives, that only 1 in 3 in US has talked or completed an advanced directive. The advanced directives allow us clinicians to speak to the patients on issues that may be uncomfortable or that may be frightened to approach. And then people will have anxiety, stress, and depression in it. So we were going to talk about a little bit about how to address and bring bad news. We use and recommend highly spike protocol. What's spikes? So, and before I go into this, earlier slide talked about family meetings. So we all need to address this issue when patients are not at a level where they are very sick or not able to express their wishes. Family meetings are very important. Should happen at every house with our loved ones, elderly or young. Anybody above 18 is able to complete an advanced directive. Things happen, and they happen fast at times. If you don't have your advanced directives signed and written down and express your wishes, then the statistically possibility of your wishes being complete is 50-50. Now, how do you talk and bring a bad news? The first one that you need to look at is the setting. Okay, it's very important. You know, I know we are all busy as clinicians, doctors, nurses, social workers. We have so many patients to take care of. But when we're talking about end of life and talking about a goal setting discussion, you have to take time away. You have to make sure the setting is appropriate. If you are going to see a patient in the room, you introduce yourself, find out who else is in the room, and make sure that the patient is okay to have that discussion in front of the people they are in the room. Then you it's always recommended to shake a hand, hold their hand, and keep an eye level contact. You know, if you want to take a chair and sit down, it's okay. I remember there was a patient once that were on the floor level. But, you know, he was a fall risk, and his bed was right at the lower level. So I sat down on the floor, and everybody looked at me. What are you doing, Dr. I said, "Well, I'm doing what I'm supposed to do. I'm talking to the patient, giving them importance, make them feel important. Okay, make them feel that you can hear them. So that's very important. If you're sitting in a place with, you know, with chairs with other family members, your posture, your body language is very important. So you sit, you know, with your hands on your lap or on your, and look at them, and please turn off your phones and your laptops and your computers. I see it all the time. Physicians coming in the room with a laptop on their hand, they hardly look at the patient because they're doing all these EMRs and recording, but not at this time. The next step would be perception. That means you need to find out what patient's understanding of their disease is. And if you look at the studies, 90% of the patients know what's going on. Okay, and there are certain cultures, you know, like in Asia, other countries in Africa, where the family members will ask you not to talk or tell the diagnosis. But guess what? Patients already know. Okay, so you have to find out what patient's understanding of their diagnosis is. The second one, then the third one is an invitation. You invite the patient and you ask them how much they want to know about their disease. Some patients may not want to know the whole condition, but be honest, be truthful, and tell them what's wrong. Then K is be direct. Don't use medical jargon. You know, use layman terminology. Use, look, you know, your organs are failing, your kidney is not working, your heart is not working. And, you know, somebody with ejection fraction of 10%, you know, is not responding to aggressive treatment. You need to let them know that their heart is failing, and then be empathetic. You use words that are saying, like, unfortunately, you know, this is not the way we all hope that it's going, but this is happening, and we have to discuss this. Now, there may be times when the family members or patient get upset, and if that happens, take a break. The conversation, you should not go into the conversation with a mindset that I'm going to accomplish something today. Okay, this is an ongoing conversation. So if you have to end and there is a time when their patients are or families are upset, you can end and ask them if you can come back and have this discussion when everybody is calmer. So that's important. Then at the end, your goal is to get a summary out of it. You know, try to get a goal setting and see how you can help. And again, you know, you can't win them all. There may be times when patients and families are not ready. You just broke a bad diagnosis and you're giving them, but keep hope alive. You tell them, you know, I usually, when I go into a palliative care consult, usually tell them, look, we are here for this is an informational session. You don't have to make a final decision today. So you can come back and give them time to discuss and absorb all this. So these are the SPICES protocol, which are really recommended.
And Dr. Waris, you covered a whole lot here, and we're going to try to unpack and give the audience tools, because this is one of the hardest conversations you will have in your life. But I think if you practice some and you utilize some of these tools, it may become easier as you have more of them. So these are some tools to have those conversations. Dr. Cottingham, help us utilize some of these tools.
Exactly. I can walk you through a situation. If a patient is going to, say it's a parent, is going to their primary care physician or to their heart specialist or their kidney specialist, And so have a conversation about their most recent, like their workups, whatever kind of studies they've done or lab work. And knowing that conversation is not really going to be seeking additional treatment or finding what kind of treatment is going to help continue a quality of life versus the quantity of life. Asking the family to come, asking who their support people will be to come with them, and using technology to help engage the rest of the family. Because as we know, not everybody's family lives close together. And we've had episodes or occasions, and even in my own family, where the decision maker of the family is in another state. Bringing them in on the conversation through a phone call or a group phone call and asking them, looking at what your dad is experiencing now. What is it that is quality for him and quality for you? What is it that you want to have from these treatments or have from your medications? And really, what is the minimum level of physical functioning? And that's kind of a big term right there, physical functioning. Is it is it to the point where someone that has a cancer diagnosis, is it seeking treatment until it's the point where they're no longer able to get out of bed or able to toilet themselves or able to get to the kitchen to fix themselves a sandwich in the middle of the night? And would you want to be kept alive if you can't make decisions for yourself? So if there is somebody has end stage heart disease and they have something that brings them to the hospital and they're rendered to a point where they really can't make decisions and somebody needs to speak on their behalf, what do they want to have done? The conversations among the family members, the decision makers, the caregivers really need to be expressed and documented so that everyone is on the same page. And do you want to be kept alive in a nursing home? Nursing homes are assisted livings. Is the end of life, is the care that's being rendered in their situation, is that where they want to be? Or do they want to be home? Or do they want to be in a different setting? So these are great conversations to have with everybody that's involved in the patient's care.
Dr. Cottingham, you touch on a very important issue. Usually these conversations are not one-on-one, the physician and the patient. Usually you have a whole family that is very concerned about their loved one, and they all could be in the room, they could be on their phones. However, you have to navigate, and as a practitioner, you need to navigate the whole family dynamics because this is not one person alone. So, Dr. Waris, we were talking about quality of life. Some family members may try to define quality of life as how it is for them, but not necessarily for the patient. So if I'm trying to respond that on behalf of my mom, I may have really high standards for myself or low. I don't know. Have you encountered that, Dr.
Yes,
Waris?
all the time. It's a very good question, and the best way to deal with it is, guys, fill your advance directive. Write down your wishes, your goals. It's very important that you write your goals because there may be times that you may not be able to express them verbally because of your condition. And I had a patient who told me in the clinic that his best day is when he's watching football, eating chocolate ice cream. And I asked him why not vanilla. He said, "Man, that doesn't taste good to me." So his goal was to continue to do that. And he said, "Doc, if I can't do those two things, I would rather not live." That's a big statement. So I told him, have you finished your advance directives? Have you told this to your family? Well, no, I haven't. So that's the time when I brought that up. So you need to write it down. I see that all the time. Patients go to the hospital, recurrent admission, and they're being sent to nursing homes for rehab. Patients are not even in a condition to continue rehab. They're completely bedbound. But the goal should be ask the patient what they want. Do they really want to go to a nursing home, leave their house and go to rehab? If not, you should have the rehab or physical therapy come to their house. But that's the first thing we do. Well, is
Yeah.
not doing deconditioning, you have to send him to rehab. But find out what patient goal is. The other thing that happens, and that has happened also, is that, sometimes it's very important that once you finish your advanced directive, you discuss that with your family. It should not be a love contest. Okay. You need to pick someone who is going to be your advocate and follow your wishes. It could be a friend, a neighbor, could be anybody, someone you trust that who's going to follow your wishes the way they are written. We had a case that a family member kept telling us that patient has advanced directives and wanted everything done, but she never brought it to the hospital. So we had to get legal team involved and find out if the person has an advanced directive, we have to have it on chart. So look for it and ask patients if they have their wishes marked down and bring them to the hospital.
So it's important to have the forms completed, but it's also important to have those conversations with your loved ones and to designate someone who you trust will advocate for you. So one thing that we probably, Dr. Cottingham, you probably see this more in hospice is families that push the patient to go for treatments that they perhaps don't want anymore. And that's where this question of quality of life for you comes in. What can you tell practitioners that they can do when they see that, then they see the daughter or the son are pushing too hard for a treatment that might not bring any quality of life to the patient?
Right. It's a lot about education and communication. When it comes to the treatments, what are the side effects of the treatments? And what would that do to impact the quality of life and the goals that the patient is trying to attain? Those are the most critical conversations to have. And here with us, the ethical dilemmas. You know, the burden, the gift of communicating your wishes and goals with those that are around you are just paramount, because otherwise you're leaving someone to make decisions that they think are right, but they're not quite sure. And they're speaking on your behalf, and you're not telling them exactly what it is that you want, not being honest and truthful because of the guilt. There's a lot of guilt and fear of not doing the right thing. With advanced directives and other kinds of documents like MOLST, they can change. So as the person's situation changes, as the conversations continue, and they learn more about their disease process, they learn more about what treatments are acceptable, and their goals change, and that's okay. But we want to have this information available for the caregivers. We want to have it available for the professional caregivers that work in the acute care settings, the long-term care settings, because they don't want to be burdened with events that don't sit right, if that makes sense. Because if you have someone that is end stage, everybody knows it's end stage, and there's no documentation as to what their wishes are. You have to do everything, and that can sit very hard on the professional clinicians' parts when treating patients that are end of life. So this is very important.
So we have a quote by Dr. Shahid Aziz from his book, Courageous Conversations, that says the mere availability of a treatment of a procedure does not obligate you to offer it as an option. Dr. Waris, you want to say something about this?
Yeah, so we see it all the time, and I again stress the clinicians, nurse practitioners, nurses, and social workers to please look and make sure that you're following the advanced directives if the patient is not able to communicate. We see it all the time, that there is an advanced directive in the chart. It says they don't want artificial nuclear hydrogen, and next thing you think they have a pack tube placed in. And guess where they get the consent from? A patient who has dementia. So you need to be very careful. That's what patient directed and shared decision making is all about in this era. Okay, we should not be imposing our or family's wishes to a patient who's not able to make decisions. So many studies have been done in advanced dementia, patient with Parkinson's, severe, tube feeding and artificial nutrition does not prolong life. It actually shortens life. Okay, people think that they can prevent aspiration. No, they can't. So before you do a procedure, that's when you have to have that meeting with the family. I usually ask family when the patient is at the stage that they're not able to converse and they don't have advanced directive. I sit down and the first thing I ask them, would your mom or dad would want to live like this? Have he ever discussed this with you? Not, and even if they have not discussed medical conditions and their end of life issues, what is the quality of their life? What do they do on a daily basis? Would they want to live like this, attached to the machines and a tube feeding and living in a nursing home?
Yep, we have a comment on the chat box, and yes, we want to invite everybody to participate in the chat box. And she says, I was taught by a veteran oncologist that you need to know when not to treat and learn how to refrain yourself from offering treatment unnecessarily. Thank you very much, Hameen, for that comment. And the other part to this feeding tubes for patients with any condition that it doesn't bring any quality of life, it's easier to put them and then to remove them is the hard part. And that's a tough decision for the entire family. And that's a burden and memories that people have to live with after you go through that. So gotta think about that portion as well. So another quote from Dr. Shahida C's Courageous Conversation says, our job is not to keep people from dying no matter what, but to take care of them, decrease their suffering, and help them heal, even if they are dying, so that they live and die as well as possible. And that's really the essence of what we do in hospice. Dr. Cottingham, you want to say anything about that?
It's really about the quality of life. And looking at the situation, our job not to keep people from dying no matter what. How far do we go? How far does the patient want us to go? And the communication of their wishes. And letting them know, again, with decreasing their suffering and help them heal. Helping to reframe hope. Hope may not be for the cure, but it can be for comfort. It could be attain a certain some family event. Hope to be able to have enough comfort, but still have some relative lucidity, being aware of when a family member is coming back home after being gone for several months, or if there's a huge family occasion that's coming up, an anniversary or a birthday that is really something important for them to celebrate. Making sure that they're able to enjoy, because that's what life is all about.
Yep. Hope reshapes, right? I don't think some people worry that if their loved one is in hospice, hope is going to go away. I have not seen that happen.
Yes, and I wanted to bring something up at this time. There was a study done about hope and faith.
Mm-hmm.
So faith plays a big role in our life. Okay, so I usually talk to the patients and try to explain it to them that look, life is a journey, and as far as my belief, because they may have a different belief, but it doesn't end, and it doesn't have to end horrifically for you. So there was a time that I was seeing a patient in the clinic, and the 89-year-old female, and I was talking to her. I said, look, when you come to this world, you have a party, you enjoy, you have balloons and you champagne. So when you leave, it should be a celebration. You should, open a champagne. She looked at her daughter and said, see what the doctor said, you better get me a champagne tonight. So you have to keep hope alive, and faith is a big part of it, and it doesn't die with death.
No, actually, we've seen in hospice care how every year 100 patients, 120 patients that we care for are discharged because they are stable. So it's not that we cure them, but they somehow are not on a constant decline anymore. So how do we explain that? That's not all of our patients, but it accounts for 7 or 8% of our patients. So we have a slide in front of us, goals of care drive the plan of care. And what are the goals of care, Dr. Waris?
Yeah, so that's where the advanced directives
Mm-hmm.
are very important again. I mean, you've heard me said like 10 times already.
Mm-hmm.
But that's what it's all about. Your goals should be documented and reported and then communicated to your family and your physicians
Mm-hmm.
and carry them with you, have them in your record so that your plan is directed toward your goals,
Mm-hmm.
because that's what patient-centered care is all about. Now, only, there is a place in Wisconsin called La Crosse, and it's named the best place to die in US. You know why? Because 96% of that town has completed their advanced directives and they're following everybody's goal. And guess what, guys? The other part that I liked about it was that the cost of uh, living at the end of life in that town was only 18,000 a year. An average cost is 26,000 a year. 1/3 of the U.S. health cost is used at the last year, 1 to 2 years of one's life. So it's important. Not that that's the major issue, but it's important that we do that. So again, advanced directives.
Mm-hmm. Yes. So now we're going to unpack the tools. What exact words can we use when we're delivering not so good news? So what are helpful phrases, Dr. Cunningham?
There's so many different ways of phrasing these bullet points. And a couple of ways of working through them would be, as Dr. Waris had discussed earlier, being on eye level with them, whether it's in the provider's office, it's in the hospital, it's in another kind of setting, and just letting them know, I wish I had better news. I know we've explored different ways of treating your heart disease, but what we've done has maximized. We've done everything we can, and now it's time to start looking at other ways to help support you. And then you can start walking into goals at that point. And I appreciate what you do want to know and what to expect, and explaining to them what they're seeing, what's going on, helping to walk them through what their disease or their end of life is happening at that time. Finding out a baseline so you can take them further. And really, I like this one. I'm concerned. You've had 3 or 4 hospital admissions this year. We've gone through 4 or 5 different medication increases, but you're still having chest pain or you're still having shortness of breath. You're not able to walk to the mailbox anymore. And letting them kind of sit on that and think about that and process it and acknowledge that there are some things that are going on. And you can explain a little further and a little deeper if you need to at that point. And I wish that one can go many different ways of, I wish there was something more that we could do. And I'm looking into what are you hoping for? And again, that's another one that's a great lead into what their goals and expectations are regarding their disease process and what their hopes are. And let's talk about the goals to be achieved. So, and then having that great conversation and walking them back then to where they are in their disease process and how to help them achieve those goals.
Yep. I like how you're unpacking this. I am concerned, but you're also helping them see that the patient has been declining. So you are supporting them in this terrible moment, but also helping them see, because I think as a caregiver, it's very hard to see the decline in your loved one. You just get used to the downward trend and that you feel it's not so bad or not so different. But when you walk them through, the many hospitalizations and all of these changes, and you show concern for that, and I think they can see it also. This is all very painful, and I think most people are in denial, which is normal. None of us want to see all of these, but how can we hold them in their pain so they can see what we see? There's a question in our chat box that says, when there are no advance directives or medical power of attorneys, who becomes the surrogate decision maker if the patient is no longer capable of making decisions themselves?
Yeah, so we deal with that all the time. So you have to follow Maryland's surrogacy laws.
Mhm.
So if you have a partner or your spouse, the next of kin would be your partner or spouse. And if not, then it goes to your children. And there's a whole surrogacy thing.
Mhm.
So it happens all the time if you don't have an advanced directive, right? And your spouse or your partner is not allowed. Guess what? And you have 7 children. They all have to agree. It's a very difficult situation that we live, and we have to call all 7 of them. And sometimes they have one person who talks for all of them, but then sometimes they don't. And if one of them do not agree to make person comfortable, guess what? They're gonna end up in a pit tube, and they're gonna end up in a prison.
Yeah,
So that's why it's important to have your wishes documented.
it's almost a gift to your family to document that, and not only document, I would take it to another level, to have the conversations, explain why this is important to you, and of course, as clinicians, how can you make that happen when you're not there with the entire family? That's kind of concerning. But we have a slide in front of us saying name the feeling, and this reminds me of a tool to document advance directives that talks a lot about feelings, and it's called 5 wishes. Dr. Cottingham, can you tell us a little bit about that tool?
Well, the 5 wishes is a wonderful tool. And it's one that I have my own family use. And it takes a look at different situations, and it allows the person to either indicate like a yes or no, or even write a little bit of a narrative. So when it comes to feeding and nutrition, which is always a big question when you're looking at an end of life situation, what does nutrition and hydration look like for them? Is it that they want to have a tube for a limited period of time? Do they want to have or nothing at all? And that is okay. And it goes through and looks at each element of end of life care and allows the person to basically write their narrative and their story as to what they want it to be.
Mhm, mhm. Yeah, we can't recommend that enough. I think we're going to send the resources for 5 wishes. It's also been translated to all the language that I can think of, and it's a pretty good tool to go to make your wishes known. And as we talked before, also they change over time depending on where we are. So in my case, my dad 15 years ago wanted aggressive treatments. 5 years ago, he was not there anymore. So I think it's something that needs to be revised. We have a question from the audience, and it says, if a patient has completed a MOLST with their physician, but does not have a next of kin available to make further decisions, does not have medical power of attorney, can they choose to make their PCP their medical power of attorney?
That is some legal question, but I would probably say yes, if they had a conversation with their physician. But the other part of this is that's why advanced directives are very important. Um, uh, if you don't have an advanced directive, and let's say you fill the most and you say you don't want to be resuscitated, and then you go into a state of that you cannot make that decision, the next of kin can change that on. So it's very important to write your wishes. But if you have an advanced directive, then the rules cannot be changed. And even if 2 physicians can make a decision about it if they had that discussion with the patient, and physicians should avoid fetal care because it doesn't really help anyone.
Mm-hmm, mm-hmm, mm-hmm. Very good questions. Thank you to the audience for those great questions. So now we're going to try to provide you with tools. You're having these conversations. Families are really full of anxiety, frustration, fear. all of that. And we are going to give you some very concrete advice as how you can get the pressure a little bit down when you are having these conversations with families. And the first one we're talking about is name the feeling. How does that affect these conversations, Dr. Waris?
Yeah, so, when you name a feeling of any emotion, you're expressing empathy, you're expressing compassion, and that's what they want to hear from you as a clinician, because then they understand that you are feeling what they are and you are at their level. So if they're frustrated, name it. It sounds like you're frustrated, sounds like you're mad, sounds like you're upset right now. I'm going to come back and have this discussion where you're calmer. And I know you're frustrated because you you have tried so many different things, but unfortunately it's not working out.
Yeah.
So name the feeling, presents empathy and compassion.
And we can't say that enough. Dr. Cottingham, what's the other tool?
To understand. And as you see, this helps me understand what you're thinking. So by having this conversation and the discussion back and forth, you're better able to understand what their wishes are, and they're better able to understand what their choices are. And that's validating. And that helps to develop the mutual understanding, the respect, and it really treats them as the whole person that they are. And it helps you to walk them a little bit further down their journey.
Yeah, and to show curiosity, to understand where I'm feeling or why I'm feeling this frustration kind of makes me feel like you are sitting here with me, somehow walking with me, because it's very lonely, the path for a lot of caregivers. And another tool, Dr. Waris, what can you say about this?
It's that we have to make sure that we discuss and we lay down in a medical, non-medical layman terminology, what's going on, where they are with their disease, and tried, let's say, the fourth step of the treatment, fifth step of the treatment, but the disease is progressing. Now, even after you have explained everything and they want to continue aggressive care, you have to respect the decision. But that doesn't mean you stop. You keep coming back and having the same discussion. And believe me, a lot of patients at the end, they usually, if you look at the studies, 80% of Americans would rather be home when the time comes with their families and friends, right at their house, not in the nursing home. But only 20% are dying at home. Rest are dying other places, hospitals, emergency rooms, nursing homes. So that is why it's important to have advanced therapy.
Right. And respect, if we're trying to communicate respect, and Dr. Waris, you started saying, take your time, find the right setting. Don't rush through this, because people feel disrespected as if this is not important enough. And here I am losing my loved one or losing my own life. And we're rushing through this. It can't be something that is conducive to understanding my diagnosis or what I'm going through if I feel that it's another check and you move on to the next task. So taking time and making people understand that this is hard for you too as a practitioner, to be there in this pain. And it's sort of, and culturally, there's many ways that we can convey respect to many cultures. So that's another layer for another webinar. We're not going to touch that today. So Dr. Cottingham, you are really very, very savvy at support. Mm-hmm. So tell us I have seen many practitioners that feel so well supported by you. So how do you do that?
Really, the support comes from listening. And I'll do my best to make sure you have what you need. What kind of resources do they need in order to be successful in achieving their goals, or to help support them in the decisions that they make? and letting them know that there is no decision that is a bad decision. It's their decision, and it's their decision for them. And, you know, as providers, we may feel that it's not the best decision, but that's with our own judgment. And it just really propels us to continue the conversation. We may support them as they seek to do another treatment or seek to have another procedure, or support going back and forth to the emergency room to be either dialyzed or to have, you know, IV support. But with each of those episodes, just continuing that conversation. Okay, now we've done it again, and we see where you are and how do you feel, and let's look at your goals. Is this what you want to continue? Such as somebody with the end stage kidney disease, going back and forth to dialysis. You know, they want to continue to do that, even if some of their support system around them is not really on board with the patient's decision. But letting them know, okay, now you're starting to get more and more tired. You know, I support your decision, what you want to do, but this is what we're seeing. And we just want to make sure you're able to make the best decisions for you at this time. Really just listening.
Yep. And I've seen support do magic, taking your time to express it. So exploring what families are feeling. And this is where also the cultures play a big element, which I don't intend to do a whole new webinar right here, but Dr. Waris, talk to us about exploring what people are feeling.
Yeah, I talked a little bit about this before, but you know, when time comes and the patient cannot make a decision, first, if they can, then you need to talk to them about what their goals are. You know, what type of quality of life they would want. Would they want quantity or quality? And you know, and what is they're looking at this stage? You know, there are times that we had a patient at an inpatient hospice that a young patient. Her daughter was 18 and she was graduating from high school, and her goal was to have her daughter see graduate. Well, we talked to the school and the teachers and have her graduate 2 weeks before the graduation day, right at the lake, so the mother could, participate. So you need to explore what their wishes and goals are. You know, there may be patient who would who are waiting for a grandchild to be born, or we're looking for waiting for a wedding. So you explore and ask them what their wishes and goals are.
Yep. And reframing. And this is something, Dr. Cottingham, you were talking about, the reframing.
Yes. Taking a look at where they are in their disease process and their treatments and their treatment plan, and letting them know that they've gotten to a point where the treatment is creating more harm than good. They're having the seizures because of the brain swelling that's happening with their radiation treatment for their brain cancer. Looking at the third or fourth line chemotherapy treatment that's causing their stomach distress, and therefore they're unable to go to the store or go to the movies or celebrate a special day with someone else, and taking that time to reframe their hope and reframe what their experience looks like, and helping them find a much more positive outcome than having to experience the pain and the suffering that sometimes comes when we're continuing beyond where the treatments are most effective.
Yep.
I'd like to add another thing. I see that all the time in our palliative care clinic. You know, patients are throwing up, so tired, can't get out of the bed, severe pain, shortness of breath. And so I usually ask them, what is the quality of life you want? Is this something, if a fourth line treatment is making you worse and not making your disease better, and you can't even have good meal, then is it worth taking? So keep discussing those issues with them.
Mhm. Mhm. Thank you, Dr. Waris. And I think we mentioned this already. We named the feeling, we named the emotion, and we can also put it in a loving context, right? We feel these emotions because we love our loved ones. That's another good tool to have on your toolbox. And then help create a plan, right? And this is what Dr. Waris has been saying, what's most important to you. Dr. Cottingham has been touching on that. Very important to find what is most important to your patients. It's another great tool. And then once you know what's most important, then it gets easier, right? Dr. Cunningham, you want to talk about this one?
Absolutely. Once you're able to identify the goals and what their hopes and their dreams are, you can align their plan of care and have different resources put in place so they can achieve them. And really, by planning ahead, we can avoid hospitalization, emergency room visits, nausea, vomiting, pain, um, still able to get outside and enjoy time out on the deck with their family, helping to align their goals to their treatment. That is really key.
And, you've seen this in all of our slides, never too much support or empathy, and they help. And I find that they make the conversations more meaningful. And a lot of times they take less time because you are showing the empathy and the support. People open their hearts. And so this is a very important tool that we want everybody to think about. As you're having these conversations, think about what went well in each of your conversations. Now, this reflection time will help you with your next conversation because everybody has to develop their own voice to have these conversations. Dr. Waris, you want to talk about?
So, unfortunately, right now, a lot of medical schools are teaching communication skills to medical students, and we have a residency program, and we're going to address that because a lot of the residents are not from the US, they were not trained here. So we will address this there. But communication is a skill, and it can be learned. And for physicians, nurse practitioners, and clinicians, it's a very difficult part that we are all trained to save lives. But as I said, life is a journey. It's gonna happen to all of us. We're gonna get to a situation where medical conditions gonna get worse and treatment's not gonna help. The number one thing, if you're gonna take out of this, uh, is listen. Listen to your patient. Listen again. There was a study done that a physician interrupts a physician every 18 seconds. Because we can't shut our mouths. So please, if one take-out message is talk to your patient, listen to them. And despite protocol, there's so many videos out, that's the way. Get an expert, become an expert on how to converse with your patient, and you will have better results.
Yeah. So when is a good time to talk to patients, Dr. Cunningham?
When it's not an emergency. So the best time to talk about them in the primary care provider's office at a routine office visit, presenting the information. They may not be ready to talk about it at that visit, but at least you've given them the idea, you've planted the seed, and you've given them a resource. They can, show them a link on their phone as where to go to download the 5 wishes, or even if you have copies in your office to be able to provide. Say, go ahead and look over this with your family and see what your decisions and goals might be, and have a great conversation at our next visit. Any illness or hospital admission, if they're repeated visitors to the hospital, coming back in several different times to you, to your doctor's office to get yet another treatment for their heart failure, end-stage heart disease, and then the initial diagnosis of a limiting illness, being able to explore what this might look like for you, because we know that an end-stage illness for one person is not always the same experience for someone else. A hospital admission with a life-limiting illness. Those are usually the most difficult if they haven't had those conversations first, because it's a surprise. You get into all of the feelings, and it may take a little bit more time. And of course, that goes hand in hand with the ICU admission, where the person may not be able to make the decisions themselves.
Mhm, mhm. So what happens when these conversations don't occur, Dr. Waris?
Yes, and as I mentioned before, if you don't document, write down, and do an advanced directive, you will go over all of these issues. Patients suffer more. Families also suffer when their loved ones are suffering because of unnecessary uh, treatment or overuse of fetal treatment. Uh, all these is a bad outcome for the family. So if you're putting yourself and your family under burden if you don't have an advanced directive, and it gives unrealistic hope because uh, a patient is in the hospital and seeing 6 different consultants, and they're all talking differently about one organ, but no one is putting it together for them. And they hear something. Cardiologists come, not gonna put them, don't want to put them on the spot, but they would say, "Oh, your heart's doing good." Well, yeah, heart's doing good. The patient is frail, he's not eating and drinking, uh, but that gives them unrealistic hope. And then, the ethical dilemma is moral distress. If you don't have, let's say you have 7 children, and they're not agreeing to it, it gives a burden and distress to the family. Conflict, it causes conflict between them and the medical staff. So that's why it's important to have advanced directives and appoint someone who you trust, who's going to follow your wishes. And we talked about cost of care. 1/3 of health expenditure is in the last 2 years of the life.
We have a question in the chat that says, how do you approach those patients who get offended that we've tried to discuss this? And they say, I don't want to talk about it. I want all my kids to make decisions together instead of picking one single person.
So that's when family meeting is very important. And it's okay if they're upset. You come back and talk to them. You address, as we said, every admission, every illness. That's why it's important to have this discussion by the primary care physician. What happens a lot of times, patients are being admitted to the hospital for acute illness. Their primary care physician is not there, who has built up a rapport with them for years and years of practice. So this issue of advanced directives and goals of care should be addressed on a yearly annual wellness exam and should be brought up. But yeah, you can have multiple families instead of one with all the family.
And over time, things get more clear. I think this is not a one-time conversation, you're saying. And we have a couple of minutes left. Dr. Waris, quickly, when to talk about palliative care?
Yeah, so we have talked about it several times. Palliative care is symptom management, and it started at the diagnosis of a life-limiting illness or whenever the disease worsens. Any admission, recurrent admission to the hospital, ER visit, and what we do in palliative care is a team approach. We take care of the whole patient, not just their medical. We also address the social and psychological issues, and try to make sure people have advanced directives. And palliative care actually continues because it's symptom management. So when the patient has a life expectancy of 6 months or less, they can elect to go to hospice. But palliative care continues with hospice because it's symptom management. And best way to address who's hospice eligible to ask this surprise question. The other thing that I put my curiosity cap when I'm looking at hospice patient is to look at the frailty scale. What does word frail mean? F-R-A-I-L. So F is for fatigue and functional impairment. So if somebody who is requiring the activity, assistant activities of ADL or IADLs, they're not doing good, irrespective of what your disease is. Then R is for resistance. Like if they can't ambulate without assistance and can't climb 10 steps, then they are right. Then the other one is advanced diseases or advanced diseases like someone who have more than 5 comorbidities and they are not eating and tired and staying in bed 30%, 40% of the time of the day, they are afraid. And then I is for irreversible organ damage. And then last is L is for weight loss. If somebody is losing more than 5% of their weight without a cause, they're afraid. So anytime you have your frail index, then that's someone who can benefit from hospice.
Right. And we have very little time. We're going to send these PowerPoints, but Dr. Cottingham, we're available 24 hours a day, 7 days a week.
Absolutely.
Yep. And patients don't return to the hospital. We keep them out. I mean, that 98% of our patients don't go back.
Mm-hmm.
Quickly over the benefits of hospice.
Sure. As we know, the studies show that patients do live longer on hospice care when they're referred at the appropriate time. They're getting the right care at the right time. They do live better. The studies show the quality of life of the patient and the family does improve. They're able to die more peacefully in a surrounding that is most pleasing for them, and less emergency room visits and the burden of the back and forth. Less non-beneficial treatments with the side effects that go along with those treatments. Support for the family by a team of professionals, spiritual care, social work, volunteer services, music therapy, of course, registered nurses, NPs, and MDs, and peace of mind for everybody involved in that patient's unit of care, because we treat more than just the patient. It's everyone else that's helping to care for that patient and helps with decreasing the cost burden on the family.
Yeah, I see it all the time happening, especially now there's a trend, a lot of nursing homes, physician assisted facilities put their patients on comfort care and they don't call hospice. You're robbing the family and the patients of all the benefits that they can have that we listed. We have a bereavement policy for families after a patient passes for almost a year, and sometimes even more without any cost. So when they are eligible, please refer. And the 2 points that we want to take out of this is, we have 58 participants. Please go home, and if you don't have an advanced directives, sit down with your family. Even do your own advanced directives and talk to your loved ones to have an advanced directive done. If you can double it, triple it, that would be the best way. And then listen to your patients.
Yep. Dr. Cottingham, some closing remarks. We're 2 minutes over our time.
When in doubt, call us and get a referral, get a baseline. If anything, the patient and family will come out with a little bit more information as to what they can do to support where they are at that time. If they are not at that point of hospice care, we can help them find other resources. And also, it's peace of mind for the family. It makes the additional conversations that you have to have with the patient and family that much easier.
Thank you so much for this wonderful panel. Thank you. And I'm going to turn it to Lauren, who's going to explain how you do your evaluations to get your CEUs. Thank you very much.
Thank you.
Thank you to all of our panelists, to Dr. Ghulam Waris and Dr. Stacy Cottingham for this presentation on a topic that may be relevant to many. And thank you to everyone who has joined us today. We hope the information was useful to you. To wrap things up, we ask that you take a couple of minutes to fill out a short survey. Your feedback will help us to bring relevant programs to you, your practice, and those you care for, as well as allowing us to provide free education credits to you. To complete the survey, visit the chat box. You will need to click on the appropriate link or scan the QR code form on the slide on your screen now. Additionally, you will receive an email at the end of this presentation containing the links to the surveys. Please remember that you will need to fill out the survey in order to receive the continuing education credits. This was a presentation from the Coastal Caregiver Academy, supporting and empowering caregivers in our community. And we are pleased to have collaborated with Tidal Health to bring you this presentation today. At Coastal Hospice, we are here for you, and you can call us at any time at the number on the screen. Thank you once again for joining us. I'm Lauren Blair. Have a wonderful rest of your day.